David is the head of medical oncology at the Nelune Comprehensive Cancer Centre at the Prince of Wales Hospital. I'm Untra. I'm the Director of Cancer Services at the Nelune Comprehensive Cancer Centre at the Prince of Wales Hospital. So welcome everybody. So over to you, David.
Thank you, Boone. It's really a delight to welcome you all to the roundtables for 2021, and we're about to set the bar very high for the rest of the presenters for the year. So the goal of each roundtable is to exemplify the collaboration between cutting-edge science and clinicians who contribute to the development of that science and of good outcomes. So I've had the pleasure of collaborating with Professor Park for quite a long time. I don't think I even want to actually work out the number of years, but I've watched her from doing her PhD in the neurology department at the back of Prince of Wales Hospital, together with the collaboration of a number of medical oncologists in the department, all the way to her travels overseas and now being an NH and MRC Wright Biomedical Research Career Development Fellow, who has done remarkable work in this specialty of chemotherapy-induced peripheral neuropathy. So she's going to today exemplify that cross-cutting multidisciplinary approach to investigating a serious problem that our patients care about, and is part of that increasing proportion of survivors that the Nelune Survivorship Centre will participating in catering to. So with that introduction, Susanna, over to you.
Thank you very much, David, and thank you all for having me here to speak today. This whole project has been about collaboration, and so we've been lucky to have a fantastic and wide-ranging multidisciplinary team working with us, the number of hospitals, universities, and research institutes, and really the collaboration with a lot of different medical specialties, including oncologists, has been so amazing over the years. In particular, collaboration with David Goldstein has really, I think, taken this project to the next level in terms of enabling clinical researchers like myself to try to have an impact at the clinical coalface. So today I'm going to talk a bit about this work, looking at the impact of neurotoxicity on cancer survivors. What do we know about mechanisms and the tools we have to investigate them? Why assessment matters, how we can develop a risk profile of neurotoxicity, and importantly, how we can clinically translate these findings into clinical practice. So first, looking at the impact of long-term neurotoxicity on cancer survivors, there's a large and growing population of cancer survivors worldwide, over 32 million people worldwide, of which 1 million are here in Australia. And really, this means that we need to think critically about the long-term consequences of cancer treatment for cancer survivors, because there will be a very large population of people living a full life after cancer. Peripheral neuropathy is one of these potential toxicities of treatment. In a general sense, we know that peripheral neuropathy contributes to healthcare costs and reduced function and quality of life, increases disability, falls risk, increases opioid use. In general, in the population, people with peripheral neuropathy have a lower life expectancy than age-matched peers. And there's a number of causes of peripheral neuropathy, the biggest being diabetes, but also autoimmune conditions, genetic mutations, but chemotherapy-induced peripheral neuropathy is increasingly becoming a major contributor to peripheral neuropathy around the world due to the large number of cancer survivors treated with these neurotoxic drugs. And so chemotherapies in a range of classes, including platinum drugs, taxanes, vinca alkaloids, thalidomide, and bortezomib and analogs are all can cause chemotherapy-induced peripheral neuropathy. And these drugs are used to treat a wide variety of cancers, including very common cancers such as colorectal cancer, breast cancer, and other cancers such as ovarian, lung, and blood cancers. So chemotherapy-induced peripheral neuropathy causes a sensory predominant neuropathy, so symptoms of tingling, numbness, discomfort, and pain And this leads to functional problems, difficulties manipulating objects, picking things up, typing, problems with sensation, problems with balance, walking, and coordination. And so we know that CIPN reduces tolerability at the time of treatment, but increasingly we're understanding about the long-term deficits that it causes. And there's currently no standardized method to identify which patients are at risk, and really no standardization in what's the best way to assess these patients. And I guess the end goal is to develop something that could protect the nerves from this kind of damage. But importantly, we need to know how best to monitor and measure the damage if we're ever going to develop an effective neuroprotective strategy. And so quite a long time ago, we did a interview-based study interviewing patients with oxaliplatin-induced neuropathy. And these were some of the things that they said about their symptoms. And we found that a reasonable percentage of them reported issues with things like walking and writing. They reported that there hadn't been any improvement, that it was worse than they imagined. But this was only in a small qualitative interview sample. So we wanted to look more broadly, what is the impact of this toxicity in cancer survivors in Australia? And so we did an online survey in 986 Australian cancer survivors, and this was work done by Eva Battolini from our group. And so the majority of this cohort were female breast cancer survivors, but there were a range of other cancer survivor types as well. And on average, they were 3.5 years out from the completion of their neurotoxic chemotherapy treatment. And as what we found was that 77% of our cohort reported current neuropathy symptoms. And we found that those with the worst CIPN had worse quality of life, reported more comorbidities, greater pain, they had a higher BMI, and they were more likely to have received multiple neurotoxic chemotherapies. And when we looked at the cohort that were within 1 year of completion of their treatment and 6 years post, we actually found no difference in overall CIPN severity. And this really hints that for a proportion of patients, these symptoms can become long-term and persistent. We also found that patients who reported meeting the physical activity guidelines had a lower severity of neuropathy, as well as lower BMI, and they were further in time since their treatment completion. And this also hints that perhaps physical activity could be something important in modulating these symptoms. Basically, what we found predicted the severity of CIPN was older age, comorbidities, body mass index, time since treatment, and pain severity. And this really gave us a profile on a large scale of the impact of neurotoxicity on cancer survivors and how it affects people long-term. But these drugs are not only used in adult cancer patients, and they're also used in childhood cancer. So in collaboration with Tej Kandala, with Michelle Farrer and Richard Kahn, we wanted to look at the effects of lasting neurotoxicity in childhood cancer survivors. So this was a cross-sectional study of 121 childhood cancer survivors who were 8.5 years post-completion of their neurotoxic chemotherapy treatment, with a large age range of 7 to 47 years at a median of 16 years, so still quite a young cohort. And in this cohort, we found that 35% of them had clinical neurological abnormalities, with abnormalities in things like distal sensation, manual dexterity, and balance. And obviously, this was quite different from age-matched controls. When we looked at their neurophysiological recordings, we saw that there were frankly abnormal nerve amplitudes in 24%. And actually, if you look at the curve, you can see that in the cancer survivors, it's shifted so that the mean is sort of shifted lower than the control of the same age. And while this may not be abnormal at the time, it indicates that perhaps this young group is at risk of further neurological degeneration down the track, and they have a reduced reserve of their axons due to this lasting neurotoxicity. So really taken together, this demonstrates the potential impact that nerve damage can have following both neurotoxic treatment, both in children and in adults, and that generally consideration of this toxicity and other toxicities is a really important consideration going forward in survivorship research. So I'll pause there.
So thanks, Susanna. While we're waiting for other people to come up with a question, there seems to be a lot of focus in the literature and certainly in therapeutics on pain, and pain is the principal problem of CIPN. It sounds like what you're telling us is that there are a lot of other symptoms and other ways of thinking about this condition and its impact, and that pain by itself may not be the correct focus.
Yeah, so this is a really interesting question because in the literature, they're quite often used interchangeably, the terms neuropathy and pain. However, when we ask these patients, are your neuropathy symptoms painful? We actually typically get only around, depends on the agent, but typically 25% with platinum drugs, up to a higher percentage with a drug like bortezomib, say 40%, will say that it's painful. So the majority of patients say it's uncomfortable, it's unusual, it's a strange feeling in the hands and feet, but they don't report it as painful. And I think this has been a really big issue because the majority of clinical trials, even looking at traditional neuropathic pain medications, have not stratified the patient groups by the presence of pain, or they've also not used pain outcome measures. So really, the lack of efficacy of a lot of standard neuropathic pain medications may be that we're not targeting the right population. And it might be that that 25% could benefit from pain relief, whereas the other cohort would need a different type of strategy to reduce their symptoms.
So the other thing is, I believe you've started to uncover some unusual other symptom associations like sleep disorders. Do you want to just tell us a bit about that?
Sure. I think, neurotoxicity, like any effect, doesn't occur in isolation. And I guess we've been focusing heavily on neurotoxicity, but come to realize that it occurs in a cancer survivor in a whole spectrum of other conditions and comorbidities. So we did a qualitative survey. I think we had the results from around 200 people. And we found that quite a proportion reported that neuropathy specifically did affect their ability to sleep. Some patients report that it's worse at night or that it wakes them up. So I think thinking of things that may not be traditionally under the umbrella of neuropathy might be important in order to best support quality of life in survivorship.
Excellent. So we've got our first question. Do we have any data on whether the toxicity reflects a failure of neuronal function as opposed to neuronal death?
Yep. So it a little bit depends on the particular agent. So there's a whole range of potential mechanisms of neurotoxicity, and they're definitely not the same for each chemotherapy because obviously the different chemotherapies, have different mechanisms of action in general. So in some chemotherapy types, such as the platinum drugs, there is evidence that it does cause neuronal cell death in the dorsal root ganglion, which obviously has a very different recovery, is less recoverable than, say, distal nerve degeneration. So other forms of chemotherapy, such as vincristine or paclitaxel, are thought to cause more distal degeneration, meaning that they may be more amenable to recovery.
Okay, so two quick questions, and then although I'll keep track of them, we'll have to move on. So the first is the known range of time of onset. In other words, can it happen a long time, up to 5 years after? And part of that is also, can it be in non-peripheral areas, like say the thigh, if it starts in the toes?
So in terms of time of onset, the most common onset is obviously during the chemotherapy, but a reasonable proportion of patients will not get symptoms until after the chemotherapy. So for some agents, particularly platinum-based drugs, the coasting phenomenon is very prominent. And so either the onset of symptoms or the worsening of symptoms will continue for 3 to 6 months post cessation of treatment. I think it would probably be quite unusual for a new onset of symptoms 5 years later, because the coasting phenomenon should be within that first cessation period. However, obviously, peripheral neuropathy can be caused by a lot of other causes, and we don't really know how CIPN interacts with potential later causes of neuropathy. The second question was about, so it's most typically in the hands and feet. So it's not to say that there cannot be some asymmetry. I think sudden onset in the thigh would probably be unusual, but we did a study asking patients about the symmetry of symptoms, because obviously with a systemic chemotherapy, we affect that it will affect the distal nerves all equally. So you should have equal bilateral symptoms, but up to 40% of patients don't perceive it that way, and they perceive differences in their symptoms or perceive different sites of onset.
So the last, and I think it's probably a theme it'd be worth answering, would be the adult study was biased to females. Was that also the case for the childhood study? And in particular, does that mean there's a gender bias to the development of peripheral neuropathy during and after chemo?
No, so there definitely was a gender bias in the adult study, but not in the childhood study. And the reason for that is that the single largest survivorship group that's treated with neurotoxic drugs are breast cancer patients treated with paclitaxel. And they also tend to be quite proactive. So we had a huge number of female breast cancer patients answering our survey in comparison to our other types. I don't think that paclitaxel is necessarily more neurotoxic than other agents, but it's just a case of that's the largest cohort of patients that are out there that have been treated with neurotoxic drugs. And that the cohort of childhood cancer survivors was primarily leukemia and some solid tumors. So they didn't have that gender bias.
So that's great. So let's go to the next section.
Okay. So the next section is looking at how collaborative, I guess, research groups can work together to understand some of the potential mechanisms. And so I think I was reflecting this in the questions, but there's basically studies have postulated that neurotoxicity can develop at virtually every level of the peripheral nervous system, from the distal nerve terminals to the dorsal root ganglia. And you can see that there are many potential sites of toxicity. And obviously, it's really important to pinpoint the most relevant sites of toxicity in order to develop successful neuroprotective strategies for particular agents. I'm a neurophysiologist by background, and when we came to this project, we wanted to use neurophysiological tools to try to understand maybe something about the mechanisms underlying the development of neurotoxicity, but in the clinical setting. So the most common neurophysiological tool are nerve conduction studies, and these use supramaximal stimuli to assess the fastest and the largest conducting axons, which gives us information about the compound action potential amplitude and the conduction velocity. But a related technique is called axonal excitability studies, and these give us indirect information about axonal excitability. So basically, by using submaximal stimuli rather than supramaximal, which should be around here, and tracking the changes in current required to produce a target potential, we can actually understand more about the properties of the nerve and the underlying excitability than with conventional nerve conduction studies. And this may give us more information about changes in nerve function prior to axonal loss. And this is a picture of the setup that we use. So basically, as you know, peripheral myelinated axons use saltatory conduction to pass impulses, so jumping from node of Ranvier to node of Ranvier like a kangaroo. However, underneath the myelin sheath and in the node, there's a whole array of ion channels, pumps, and exchangers that control the nerve excitability. And importantly, the driving current at the node that drives the action potential from node to node is actually more than 5 times what's necessary for action potential propagation, which is termed the safety factor of conduction. And basically this means that you can have a large amount of change in your excitability and a large amount of damage before you will see an interruption in conduction. So it really means that by the time you see a reduction in the amplitude, which is what you would see with a axonal peripheral neuropathy on nerve conduction studies, a large amount of damage has already occurred. And so axonal excitability techniques attempt to look at the function of the nerve prior to the development of this axonal loss. And so we use these techniques in oxaliplatin-treated patients, and oxaliplatin causes two spectrums of neurotoxicity. So unusually, it's the only chemotherapy known to cause this particular spectrum of neurotoxicity. It causes a transient cold-related neurotoxicity characterized by tingling, numbness, cramps, and fasciculation in the vast majority of patients. And the symptoms typically resolve within a week. However, with increased cumulative dosing, it produces a sensory neuropathy, leading to functional impairment, sensory ataxia, and sensory loss. So using nerve excitability techniques, we assess patients pre and post each cycle of oxaliplatin to look at the acute effects, and also longitudinally across treatment, so for 7 to 12 treatment cycles. So this is a single patient recording here on the left of a recovery cycle with the pre-infusion in blue and the post-infusion in yellow. And you can see this change in the sensory excitability. And this is the group data here. And this pattern of change typically reflects changes in sodium channel function. And actually on the basis of these results, Professor Arun Christian commenced a study of the potential for sodium channel blockade to prevent the development of oxaliplatin neurotoxicity. And actually, subsequent to this work, a very nice study has come out demonstrating exactly how oxaliplatin affects sodium channel function. So it's been shown that these effects are exacerbated with cooling, which matches the clinical situation, that it affects the most common sodium channel isoform that's seen in human peripheral nerves, and also in A fibers, which is the type of fiber that we record from with conventional neurophysiological techniques. So I guess this demonstrates that in the clinical setting, we can have access to these changes in excitability, which demonstrate ion channel function and hint at the mechanisms underlying the development of acute neurotoxicity in these patients. When we looked at chronic neurotoxicity, we saw a quite different pattern of excitability change. And so here is the sensory recording with initial treatment in black and final treatment in white in two of our excitability parameters across 6 months of oxaliplatin treatment in the sensory axon. And in the same time frame in the motor axon, you can see that there hasn't been change. And this really matches the clinical expression of a sensory predominant neuropathy in these patients. And so what we found was that these techniques actually identify changes earlier than conventional neurophysiological measures. So this is showing you the threshold electrotonus curve with the different oxaliplatin dose levels. And this graph demonstrates 3 different excitability parameters. And you can see by mid-treatment, you get a substantial amount of change, whereas by mid-treatment, the sensory amplitudes remain stable and only start to decline in later treatment with the development of axonal loss. And comparing these results to the animal literature, we actually found that they were quite similar to animal models of Wallerian degeneration, which is a sort of typical pattern of degeneration. And so this suggests to us that these excitability studies can pick up the signature of this degeneration happening in real time in the clinical setting in patients. So I think this demonstrates how neurophysiological tools can identify these early changes, but also that by using tools from different disciplines, we may be able to identify more about mechanisms or to find biomarkers of the development of these changes in patients. For example, we're working on a collaboration with Maria Marcouli from optometry, looking at the potential for corneal confocal microscopy to be able to see changes in the nerve fibers in the eyes of these patients, and also with gait and balance analysis, which may be able to pick up early signs of gait dysfunction that may be relevant to functional loss in patients. Thank you.
Okay, that's great. We're actually getting a question which perhaps comes out of understanding mechanism rather than specifically about the tools, but is there any evidence that molecular targeted drugs that are used in the context of a neurotoxic drug exacerbates or has a worse outcome?
I think it's an emerging area, so it's not really known yet. I get there has been some discussion over whether bevacizumab can exacerbate neurotoxicity, and I understand that that has been demonstrated in some trials and some settings, but not in all trials. And really, the mechanisms for that remain not well known. But certainly, yeah, there is a small amount of evidence that that may be something that is happening.
And another mechanistic question, though, related but different, is the central nervous system impacted by the drugs that cause the peripheral nervous problem? And if so, how would it be manifest?
Sure. So there is a spectrum of with a different range of drugs that cause central neurotoxicity. A lot of these drugs do not readily cross the blood-brain barrier and are thought to cause mainly peripheral nervous system toxicity. That's not to say that you still can't have central nervous system effects, but typically it's a different type of drug that causes these effects.
Okay, and then my question would be about, you've demonstrated the really fine science about pathophysiology that you can get out of these techniques, but they look like they might be labor intensive. What are your thoughts about whether there is a simpler tool through which you could triage and then go to the more intensive granular for those who it should be done for?
Yeah, so obviously this is really important, and I think I've got a whole bunch of slides on that later on in the talk, but obviously these tools are specialized. I mean, they can be adapted, but certainly they're not going to be adapted to the level of routine clinical use. They might be something that you might want to use more in a clinical trial to demonstrate neuroprotection because you can see the effects in real time. But in the clinic, obviously, you would need something that's not using specialized equipment and much more streamlined to triage patients into appropriate risk categories.
Okay. And just quickly, if you did have such a quick screening tool as you're going to demonstrate to us in 1 or 2 slides' time, what proportion of patients would you say would require this kind of study to really understand what's happening to them? If you took 100 people with neuropathy, what proportion should have this level of intense scrutiny outside a trial?
I think that's probably a difficult question to answer, and I think it depends on what the purpose is. This kind of technique, I think, gives us a lot of information about the time course of development of neuropathy and the mechanisms. In routine clinical practice, I think even just implementing better screening and then even highlighting for even a clinical neurological review would probably be beneficial. I'm not sure that we're even, routine nerve conduction studies, which are a lot more available than some of these more specialized neurophysiological techniques.
Okay, there's a question about exercise, but I'll ask the questioner to wait because the answer's coming. Okay, let's move straight on to your next section, please.
Okay, thank you. So this is really talking about why assessment matters. And obviously this presentation is all about neurotoxicity, but I think a lot of the issues that we find with assessment tools and discrepancies are really relevant to a whole range of areas, in particular, how we assess different toxicities in the survivorship sphere. So the question is, how do we optimally measure neuropathy? So there's lots of different ways. So I've talked about the specialized neurofunction testing techniques. There's also clinical grading scale, quantitative tests of sensation, tools which measure your fine motor skill and dexterity, patient-reported outcome measures. But there's no consensus on what is the best tool and also which tool is most suited to which use. So in routine clinical practice versus in clinical trials. And so in our current in-focus studies, we're implementing a broad range of these tools to try to understand when are these tools most beneficial. And so since 2015, we've collected a large cohort of patients, and we're currently analyzing this data to try to answer this question, what is the optimal assessment tool? And I think reflecting on the tool that's most often used in the clinic, which is the National Cancer Institute's CTCAE screening tool, which is a scale that's developed for every toxicity that exists. And we know that in the context of neuropathy grading, there's a lot of issues with this scale in terms of inter-rater reliability and even interpretation of the different grades, the objectivity of the scale and the sensitivity to change. So obviously a scale which only has these points on it is not going to be very sensitive compared to a scale that has more points. And we also know that it underreports severity of neuropathy compared to patient report. And so increasingly patient-reported outcome measures are utilized in a whole range of toxicity assessment. And so there's a number that have been validated for use in CIPN. And increasingly they've been used as outcome measures in clinical trials, but they're less commonly used in routine clinical practice. And obviously there's a whole range of tools which I talked about before, but again, a lot of these are not routinely used in clinical practice. So when you look at the clinical trials, and there's a number of clinical trials currently being undertaken, you can see on clinicaltrials.gov, intervention studies for patients with existing neurotoxicity. There's a huge variety in outcome measures used. So most commonly, there are non-validated symptom scores and validated scores such as the total neuropathy score was only being used in 4 out of 48 studies. And neurophysiological studies were only being used as a secondary outcome measure in 6 of 48 studies. So I think this also really underscores the need for a standardized assessment package because like in many areas, it's been difficult to form consensus on what is a successful trial. And typically the next trial will have a different result and there's a lot of variability in which measures are used. And as an example to illustrate why the particular assessment tool you use is so important, I'm going to talk a bit now about genetic risk factors for neuropathy. So there's been a lot of studies, just a couple of them are shown here, looking for genetic risk factors for neuropathy. So you have patients that receive the exact same dose, but they have very different toxicity outcomes, which really underscores the fact that there's individual specific factors which account for this difference. This was a systematic review a couple of years ago now, but basically it highlighted that there's been a lot of discrepancy in these genetic studies and a real lack of consensus on which genes are risk factors. And so in a collaboration with John Kwok and Michael Friedlander, we looked at 454 patients with genetic and clinical data from the ICON-7 trial, which was a trial in ovarian cancer looking at paclitaxel and bevacizumab treatment. And there were actually 2 different methods of assessing neuropathy in this trial. And so one was the standard National Cancer Institute scale, and the other was a patient-reported outcome, although it only had 2 questions on peripheral neuropathy, which you can see here. So when we looked in the cohort, we found that under 30% had moderate or severe grade 2 or grade 3 neuropathy as graded on the NCI scale by the clinician. And on the patient-reported outcome, we had over 66% of patients reported quite significant tingling or numbness. So there did seem to be a discrepancy, and particularly you can see here the discrepancy between patients reporting no symptoms and patients graded as grade 0. And when we looked at patient-reported neuropathy versus clinician-reported neuropathy in relation to paclitaxel dose, you can see that this gulf between patient report and clinician report actually widened with increasing dose. And there was a low agreement between patient report and clinician report. And perhaps not surprisingly, when we looked at patient-reported neuropathy and clinician-reported neuropathy in terms of genetic factors that were predictive, we actually found different polymorphisms associated with both patient and clinician neuropathy. And I suppose rather than suggesting that there are different mechanisms underlying these constructs, I think it highlighted to us that perhaps one of the reasons for these discrepancies in the field and the lack of clear associations is a lack of reproducible outcome measures, and that perhaps these constructs are slightly different. And we need to be clear what we're measuring when we're looking for an objective marker for a risk factor. And I guess this kind of illustrates why choosing the right assessment tools is so important, not only for risk factor studies and genetic studies, but also for clinical trials in order to be assured that we're measuring the right outcomes for patients. Thank you.
So there are several questions, but actually not directly related to this. So I might come back to those three questioners, please, later. But talking about assessment tools, and particularly some of the clinical practice tools like tuning forks, reflexes, as well as what you've discussed about patient-reported outcomes. Do they have any role at all?
I think they do as part of the neurological examination. Whether they're the best tool, probably not, but I think is what we're learning over time is that you need to use a combination of different tools to come up with the best picture. I mean, what the clinicians are describing and what the patients are describing, they're not actually exactly looking at the same thing. So I think there's still a lot of work to be done in understanding for each indication which is the best outcome measure to use and how to combine different elements to understand the whole picture.
And the second question is really about the genetics work. And do you think, even though there's all sorts of different polymorphisms and every study seems to change what they said, is there a broad level of understanding? Is it at least an accepted fact or even open dispute whether there are some inbuilt variations in genetics and that make people more or less likely to be susceptible? Is that a true biological phenomenon?
I think it's quite clear that there are genetic risk factors for neuropathy, and a lot of the target genes that people are looking at relate to things like, drug transport or uptake, or things that are biologically plausible, or things to do with, neural repair or something like that. I think increasingly it's what is becoming understood. There's a few genes that are coming out more strongly now, but I think it's likely to be a polygenic risk model. So again, I guess, it's rather than finding one gene in which a polymorphism will explain all of this variability, it's likely to be a whole suite of genes that produce that additive risk. And that may be why, looking on a single basis, you see these different effects in other studies. But I think some work is coming out now trying to build those models together to understand how even sort of small fluctuations in risk can add up to the big differences that we see in clinical groups.
And so one last question before we move on. Do you know roughly what proportion of trials involving oxaliplatin had CIPN recording and PROs as an outcome?
I mean, that's a tricky question. At the beginning, obviously they all measure neuropathy because it was known from the very beginning to be a neurotoxic drug. Most of the early trials would not use patient-reported outcomes, and they only use the NCI. I think certainly in the past 5 years with oxaliplatin, it would be quite unusual to not include patient-reported outcomes. And I think given that everyone knows about the issue with neurotoxicity, a lot of the big trials now are using these outcome measures. And in fact, there's a lot of studies coming out from the collaborative trials groups in the US looking at this data, comparing the patient-reported data with the clinician-reported data from these large-scale trials over there.
And just one quick one, because I'm conscious time is slipping away and you've got two more topics. The diabetic patient, do they get worse CPN? And are there any other medical conditions that may worsen? Oh, I think that's coming in your next section.
Yeah, that is risk factors in the next section.
Okay, so we can skip that because you're about to answer that. Okay, so let's go straight into your next one.
Okay, thank you. And so this is talking about the development of the neurotoxicity risk profile. And I guess some of these elements we've touched on in the previous sections, the need for a polygenic risk score and the fact that this is work that's still in progress, but there's a range of other risk factors that may influence neurotoxicity. So some of these are treatment-related, things like treatment type and dose, and some of these are individual-related, such as comorbidities, age, and obesity. But there has been some limitation for the reasons I've pointed out before, small sample sizes, the lack of standardized assessment tools, which has limited in previous studies the ability to pull data. But probably in the last 5 years, there's been more, at least standardized use of patient-reported outcome measures in trials. And so there are more ability to pull this data in future. And so just reflecting for taxanes and oxaliplatin, which are the most commonly used neurotoxic chemotherapies, some of the potential risk factors, older age consistently comes out of analyses. Treatment factors such as paclitaxel being more neurotoxic than docetaxel, comorbidities such as complications from diabetes and pre-existing peripheral neuropathy, increased weight and reduced physical activity also being risk factors for worse neurotoxicity in taxane-treated cohorts. And there's been quite a large number of large-scale studies looking at these risk factors in large populations. In oxaliplatin-treated patients, a lot of the same risk factors have been identified, but they've probably been less consensus. And so some studies have found an effect of age, but not all studies. Some studies have shown an effect of treatment factors, with particular regimens being more neurotoxic than others, but not other studies. With oxaliplatin-treated patients, there's been a lack of consensus about the role of diabetes, and I think partially that's because studies have been looking at diabetes itself as a risk factor, not diabetes neuropathy as a risk factor. So for diabetes itself, some studies have found it as a risk factor, but a range have found no additional risk of neurotoxicity. And also things like alcohol consumption, which can also produce neuropathy, may be associated with CIPN risk. And weight also coming out with obesity being associated with CIPN risk. And so Hannah Timmins from my group did a recent review looking at these metabolic risk factors in taxane and platinum treated patients. And she found that the best quality evidence was for obesity as a risk factor, but that there was still insufficient evidence for low physical activity and diabetes in understanding the role of these risk factors in these cohorts. And so now I'll just present on a study that we've done with our cohort, looking at 333 paclitaxel or oxaliplatin treated patients. And again, the majority of these patients were female breast cancer survivors, because that's the largest group that we recruit to our studies. And these patients were within 3 to 12 months of their neurotoxic chemotherapy completion. And this was work done by Dave Mizrahi from our group. And so we examined a suite of standard pre-treatment blood and clinical factors, and we found that CIPN severity was worse in patients that were older, similar to previous studies, in patients that had a higher body mass index. We also found female sex, but obviously that would need to be replicated in more balanced cohorts. Ours was predominantly female. And we also found that lower hemoglobin was associated with greater severity of CIPN. So in our cohort, 25% of the patients had hemoglobin levels that were reduced outside the normal range. When we looked at the neuropathy gradings of these patients, we found the low hemoglobin patients had objectively worse neuropathy on neurological grading scales, neurophysiological measures, functional measures such as the groove pegboard, as well as some sensory discrimination tasks. However, when you look at the unilateral association of hemoglobin with neuropathy severity, this is the neurological grading scale here, the unilateral association is actually quite low. And I think this is an important point that's increasingly coming through in this kind of research, and I think probably a lot of toxicities, that similar to the genetic picture, there's likely to be a whole range of risk factors that work together to increase risk. So we're unlikely to find a single risk factor which can explain all the variability. And putting these risk factors together, which is what our next step is going to be, would enable us to better monitor these at-risk groups based on a variety of different factors. And obviously understanding the contributions of things like obesity, hemoglobin levels, and age will require us to do longitudinal analyses of how these risk factors interact over time.
One quick question is hereditary neuropathies and carriers, and whether that's a risk factor. Is it known, or is it too rare to have been studied?
Yeah, certainly that is known, particularly with vinca alkaloids, but I think with other chemotherapies as well. There are many case reports of patients who had previously undiagnosed hereditary neuropathy being, I guess, sort of dramatically exacerbated by chemotherapy. So that is certainly a known risk factor, although, you know, the number of people in the population with that as a risk factor is low.
And then lack of exercise as a risk factor, and in particular, is it, which comes first, the neuropathy preventing exercise or sedentary lifestyle contributing to?
You know, this is one of those chicken and egg scenarios where we really don't know the answer, and it's going to be very complicated to unpack it. It's obviously physical activity. It is going to be multifactorial anyway in the effects that it causes. So I think we still need more studies to determine if it actually influences CIPN risk. Again, I think it's, you know, there's going to be instances where you have people who are very active that get very bad neuropathy, you know, and vice versa. But I think it probably will be a contributor as part of a multiple risk model.
Okay, I think in the interest of time, because there are a number of questions which I can bring together at the end. So let's jump straight to your fifth one.
Okay, so this is really looking at how we can translate this research into clinical practice. And so we've gone through the predominant way of assessing neuropathy in clinical practice, which is clinical grading scales and its limitations, and also the different ways we can also assess neuropathy. But I guess ultimately it comes down to what is actually practical to implement in the clinic. And so we did a Delphi study a few years ago and identified 117 distinct assessment tools. And we had a Delphi panel that didn't come up with an assessment on which one was the best tool, but we found that people rated that only short questionnaires or patient-reported outcomes would rate well for effort. So this told us that if we were going to design a screening tool, it had to be something that was very quick and implementable in the clinic. And so we actually designed a simple screening tool, which was based on a combination of short form patient-reported outcome and also some tuning fork vibration testing, which is just about the quickest neurological examination that you can do. And we implemented this in a number of patients and got a number of very helpful clinicians and nurses to do this in patients. But what we actually found in the end was that this pilot tool, including vibration and patient-reported outcome, didn't perform any better against other screening tools. So patient-reported outcomes of only 2 questions and that sort of thing. So really what this outlined to us was the good news is that even if we implement a single item patient-reported outcome measure as a screening tool, this will already improve the screening that's available in the clinic. And obviously that's the easiest type of tool to implement. And so currently we've just received a Sydney Health Partners Implementation Science Grant in conjunction with Peter Grimison from Lifehouse. And we're going to determine the feasibility of enhanced clinical screening in the clinic. And so we've chosen to take 3 patient-reported outcome screening tools to see which one performs the best and to get them used at the day therapy to try to see, is it feasible to improve the screening? And so we're going to use paclitaxel, oxaliplatin, or bortezomib-treated patients and test this approach. And so these are the screening tools that we've chosen to use. The PRO CTCAE, which is the patient-reported outcome version of the NCI scale, and the PNQ questionnaire, which came out the best patient-reported outcome in our Delphi survey, and also the EviQ screening tool, which is freely available on the EviQ website, but hasn't been formally tested or validated. So we thought it was important to try that in the clinical setting. And so hopefully in the next year, we'll be able to demonstrate how we can implement this improved screening in the clinic. And the next stage will be the development of a clinical pathway. So once you identify these higher risk patients, what comes next in terms of screening, referral, and triage. And so currently there is a prevention and management guidelines by ASCO, which doesn't cover assessment. And so we envisage that our clinical pathway will complement those guidelines and try to indicate what's the best way to assess these patients and to treat them down the pathway locally. And so for the final bit of the presentation, I'm going to talk a bit about rehabilitation, in particular exercise-based rehabilitation. And so we did a pilot study in patients with existing chemotherapy-induced peripheral neuropathy, which was an 8-week pilot study with an 8-week control period. And what we found was that we had significant improvements in both patient-reported and objective neuropathy as measured by a neuropathy grading scale. And so we actually had a range of improvements on other things as well: quality of life, mobility, balance, and reported disability. And this is one of the particular individuals. So you can see that the sort of intervention is quite targeted. So this individual was very active at baseline, but found that his chemotherapy neuropathy affected his daily surfing. And so by tailoring the intervention to his exercise level, he was able to have great benefits to his own particular quality of life and the activities that he wanted to do. So based on these results, we've now commenced on a phase 2 randomized controlled trial of exercise, which is recruiting at Prince of Wales, St George, Mater, Northern Cancer Institute, and Chris O'Brien Lifehouse, looking at comparing an 8-week exercise intervention in the clinic with no care, and then the people in the no care arm will also receive later an 8-week home program. So we can also look at home versus clinic delivery of this intervention. So I think these are just some strategies for how we can implement these results into actual benefits for patients. In the absence of a neuroprotective strategy, what we can do to improve rehabilitation, and importantly, what we can do to improve screening in clinical practice to identify these patients who are at risk of neuropathy. Thank you.
So excellent. So there's a raft of questions. So I'll just get one other concept across from you, is this concept of adaptation, how people deal with a chronic persisting problem, and whether you think you've identified issues about adaptation in this context and how to foster it.
Yeah, so I mean, adaptation is a very difficult construct to objectively measure, but I think it's certainly extremely important. And so sometimes we see people that over time their symptoms have improved, but if you look at their neurophysiology, they have the same severity of neuropathy that they had, a year previously, but they've managed adaptive strategies to deal with their symptoms, changing their footwear, changing how they do things. Even with the exercise intervention, a lot of that is about, I guess, empowering the patients to feel more comfortable doing their daily activities with their neuropathy. So people report a lot of fear of falling, that they worry that they're going to be out of balance, that they need to watch their feet, and that produces a lot of anxiety that they don't want to move in unusual ways, and they reduce their activity further. And so by implementing the rehabilitation exercise study, that confidence can be improved, and then they can feel more comfortable. But I think that's also a form of adaptation. So the underlying deficit may be the same, but it can be dealt with in different ways.
And so the other point is about strategies and treatments is the bottom line about the lack of reversibility, that there's accumulated injury to neurons, which I think you said, but more importantly, developing strategies to reduce cumulative exposure as opposed to strategies about trying to get a neuroprotective drug?
I think it's a combination. Obviously, if there was a drug that could protect neurons, of course, that has been very difficult to develop, not just in this indication, but in a whole range of, neurology. Definitely, prevention is a lot not easier, but I guess more beneficial. So once you've lost some of these axons, again, it does depend on the type of damage. So damage from, paclitaxel or vincristine is generally more recoverable, and you can see, depending on the mechanism of damage, you can see recovery. And in a lot of patients, there will be complete symptomatic recovery. It's just that in this proportion, it becomes very chronic and goes on long term. That I guess we're really focused on, can we identify those patients early, and ideally intervene with some sort of preventative strategy in the absence of a neuroprotective drug, or at least then be able to target them to rehabilitation.
And I just might add one question who was asking about continuing with the same drug once CIPN appears. That is clearly not what we do. And the standard oncologic approach to the development of CIPN is to reduce and or stop the offending drug. But unfortunately, once neuropathy has occurred, stopping it doesn't necessarily reverse the problem. And then all of the things just talked about adaptation and strategies comes up. But for you specifically, Susanna, this other broad question, I think, is can you comment on how specific the damage is to nerves, or is this part of a broader spectrum of tissue damage, but neuropathy is the one that patients can report on? This broader concept of survivorship and toxicity and where neuropathy fits in.
Oh, I mean, obviously, neurotoxicity is only one of a suite of potential side effects that patients can experience, both from their cancer and from their cancer treatment. And so I think it's important that it's viewed in the context of other problems. You know, for example, we were discussing before sleep dysfunction that might be specifically caused by neuropathy. Obviously, there's a lot of other causes that may also impact on sleep dysfunction that operate in cancer survivors. So I think increasingly we need to look at how we can treat the whole patient, and neurotoxicity is one component of that side effect profile.
One last quick question, because we've got a number of consumers who've attended our session today, and one burning question is about the role of vitamins, in particular the group B vitamins.
So group B vitamins are generally known to, like, if you have a deficiency in vitamin B12, you can get a peripheral neuropathy. So I think it's a standard practice that for patients at risk of neuropathy or that have neuropathy, to make sure that their B vitamins are adequate. I think there have been some studies looking at whether they could prevent or reverse symptoms, and those studies have not shown positive results.
Okay, great. And functional electric stimulation is the other one.
Yeah, so this one is quite an interesting one. Increasingly, there are some studies coming out that it might have benefit. From my own experience, individual patients have pointed out that some of them find benefit. So I think it may benefit some people, but definitely not across the board.
Great. So we're 1 minute over. I'm obviously biased and thought it was an outstanding session, but I'll let Boone say what she thinks as an independent. Boone, you're muted.
Right, okay. Yep. I was just complimenting you, Professor Goldstein. Thank you for your masterful facilitation as usual. Thank you, Susanna, for a very interesting talk. Quite an eye-opener for me, I think, to understand the scope and the caveats of the research. So thank you once again. And I want to call premises of this Randwick Precinct Cancer Roundtable Program is to enable and facilitate research collaboration. And to our audience who have ideas or would be interested in pursuing a collaboration, please feel free to get in touch with each other or to contact David or me, and we'll be happy to help as we're able to. So thank you once again, Susanna and David. And for next roundtable program, that'll be on the 9th of March. The title will be on cancer shared care, and we're delighted to have Dr. Winston Liao from St. George Hospital, and also Professor Mark Harris from the UNSW to speak with us in 4 weeks' time from today. So thank you very much, everybody, and have a good day. Goodbye.
Thank you.